All right, it is 9 o'clock, which is lovely. Good morning, everyone. Welcome to day four of Brain Turns. Day four of 2024 Brain Turns Summer Extravaganza. People are still rolling in. Good morning, everyone. Thanks for coming along. Um, a little bit of change of plans because this is live and real, and medicine is complicated and busy. But I am not John Bookvar, as you may or may not know, and Hold on one second. I'm on Brain Turns. Do you need me right now? No. Sorry guys. As you can see, things change. So I'm not John Bookvar. John Bookvar unfortunately wasn't able to make it. So I'm going to do the innovations in neuro-oncology discussion. We have an awesome talk, hopefully by our PAs, who will join in and tell you about what physician assistant life is like. I will tell you that advanced care providers, PAs, NPs, these are absolutely integral into our day to day. And we'll talk a little bit more about that before they come on, and I'll introduce them. Super important job, super important profession, and really fun way to get into medicine. And then Dr. Motivala, unfortunately, has an emergency and isn't going to be able to do the neurosurgery and pain talk today. And so we're probably just going to end Brain Turns early today at 11 instead of 12. And we'll try to reschedule her. So anything I'm missing? Any housekeeping, Hannah or Christy or Samantha?
So I just received a question in the chat about whether or not the participants can turn on their cameras and use their mics. That's been disabled. Just to make sure there's not like voices popping out of nowhere, and it's just for us to make sure that this is like as clean as possible for a recording when we post it on the YouTube channel. I'll post the link to the YouTube channel in the chat for everybody. I've posted day 1 and day 2 of the webinars on the YouTube channel. I finally got the recording from yesterday, so I'm going to be working this morning on uploading those videos to the YouTube channel. It's going to be directly on the brain or on Lenox Hill Neurosurgery's channel. So I am going to share the link again to the playlist of webinars that are currently published in case you missed the first 2 days. And then by this afternoon, day 3's webinars will be posted on the YouTube channel as well.
That's so cool. Obviously, it's a YouTube channel. And so if you want the certificate, you got to do the survey, you got to be a part, you got to be registered. But that also means you can just share this with whoever you want, and we won't know or care, which means that this is like democratic sharing of information, which is amazing, right? I don't know. Wow, there's an AI assistant taking notes for this meeting. Are you guys seeing that in the chat? They're helping a lot of people. That's so cool. So wait, I'm gonna give a talk. It's gonna be cool. You guys are gonna love it. I don't know if we also have the auxiliary brain team watching, I think, in the other room. Um, I'm actually writing on this other computer that I have over here a paper about integrating spatial computing into the operating room. You know how the Apple Vision Pro came out and everyone's like, it's a spatial computer, and that's like a really cool idea, but everyone's also like, how do I use that? What do I do with it? Well, it turns out that I think it's a great idea for intra-op use. And so we've explored a little bit, very prelim, but this is going to accelerate really fast. These large language models, these AI assistants, I use this on a daily basis. We have this app called Playback that we've talked a lot about before on Brain Turns. And even today, I was on the phone with a patient of mine, and I just hit record on my screen, and it listens to the encounter, and then it summarizes it into a usable note that I can then deposit. So it's efficiency, it's time. It allows me to really pay attention and listen to what I'm saying, not just like trying to rapidly type things, because I know I got to be here at 9 and there at 10 and somewhere else at 11. So this is just such an exciting time, and all of you are going to really reap the benefits of this. And I'm super excited, and I get super excited when I hear about it, as you can tell. So without further ado, I'm going to share my screen.
I'll stop sharing mine.
Thank you. And we are going to talk about innovations in neuro-oncology, but specifically something very kind of near and dear to my life right now. And for those of you who know, and I don't expect any of you to know, and I don't know why you would know, but I do a lot of work with something called connectomics now, and we're going to talk about that and how we're using it in the brain tumor space. And I call it the new mindfulness, right? John Bookvar kind of was the big mindfulness guy here, still is. Talks a lot about, the importance of meditation and grit flowness, I think was his term. And you can see that talk in an old episode of Brain Turns on the website. Remember, you can look at any talk that you might have missed on the website at some point. But anyway, connectomics has to do with understanding how the brain talks to itself. And there's an architecture to the brain. It's not just this pile of medium tofu that exists in your head that miraculously makes artwork and poetry and schedules your day and raises children. It's a series of really complicated architectural designs where individual neurons are firing in synchrony with each other locally, but then they're also firing in synchrony with each other across the brain. And this is happening constantly, where there's this constant kind of fluctuation and these waves of electrical information and synaptic information or neurochemical, electrical information that is making you exist, right? It's perceiving everything around you through your body, your vision, your taste, your sight, your smell, your touch. It's putting that information into some sort of context in your brain to allow you to perceive reality. Anytime you have an idea, it's allowing you to generate that idea in an outward, projected movement. And it turns out that, brain tumors arise in the brain right in the middle of this landscape of really complicated connections. And we have, for the past 100 years, just taken them out and didn't think so much about this, right? We started thinking more and more about it when we realized, okay, when we take away someone's language, we hurt them, or when we take away someone's movement, we hurt them. But until recently, it's been very difficult to see the architecture that's underneath that. And it's also turns out that it's different in every person. There's some kind of rudimentary underlying framework, but then every person kind of utilizes this different. And so we're going to talk a little bit about that. And so, like I said, the new mindfulness. That's me. I'm here. Most of you know me, I think, because I give all the lectures at this point. But who am I? So I'm a professor of neurosurgery here, hopefully associate soon, but we'll see. I run a brain and spine metastasis program here. You remember there's different types of brain tumors, ones that come from the brain. Those are called primary, like gliomas or meningiomas, things like that. And then there's metastatic tumors, which come from somewhere else. Today, we're going to focus on the primary brain tumors because that's where the majority of the research involving connectomics comes from. And I'll explain a little bit about why a little bit later on. And then obviously, if you have social media and you don't follow me, we're fighting because, it's nice to follow people and you learn stuff. All right. So primary brain tumors, why are they important? Primary brain tumors arise in the brain and they disrupt the brain. All right. They're infiltrating, which means that the cells are going through the brain itself and they're recruiting normal cellular components into being that tumor. So astrocytes, microglia, neurons, all of this stuff and is getting incorporated into the tumor, and it's destroying it as it grows, but it's also infiltrating into. And so these connections that I told you are being disrupted always. It's basically like a leak dripping through a high rise, right? At some point, it starts in one focal location, but then that water causes damage next to it, and it keeps dripping down and permeating the whole framework until you have, bad water damage and the whole building falls down. What we know about these tumors is that if we take out the tumor, people do better. And we have to get all of it out, basically, what's called the contrast enhancement. So extended resection is EOR, so more is more. And that is the only risk factor for these tumors that we can change ourselves. So that's really important. And I emphasize this a lot to residents who may not know this, but you see here on the left side of the column, there are non-modifiable risk factors. So I can't change a patient's age. I can't change their functional status, meaning how independent they are when they come see me. I can't change the tumor. The tumor developed without me, right? I can't change its histology or molecular markers. But what I can change is how much tumor is removed. And we've studied this, and it turns out that safe maximal resection is improving symptoms. It's improving the quality of life for patients. the progression-free survival, and the overall survival for these patients. That's a big win, right? If you're diagnosed with a brain cancer and my surgery can help you live longer and live better, then I've done good for the world, or for your family at least, right? Maybe not the whole world. And so that's a really important concept. And this has been proven in primary brain tumors. If we can get at least like 80%, we're making a difference. It happens in recurrent tumors and happens in low-grade gliomas as well, which we wouldn't it's a different disease. We're going to really focus on the high grades here. And so we've developed all these tools to help us do this. We've got our navigation systems, which I think most of you might not know about. We take our preoperative MRI, and in the operating room, we register it to your face. So we know exactly where your brain is. And this is millimeter accuracy, meaning that we can find a blood vessel. We can find a 1 millimeter, spot on your brain using this with accuracy. It's a game changer. It's GPS for your brain, basically. We've developed intraoperative MRIs where there's an MRI machine in the operating room. So when we're done taking out your tumor, we can put you in there and see if there's any left. Okay. Only a few institutions have this. It's a really, really expensive premise, and not always that necessary. But ultrasound has gotten really good. I'm sure Dr. Benchlam talked about this yesterday, where we're able to, use sonar basically and look into the brain and see differences in tissue. You can imagine the difference here is granularity. You can't see at a microscopic level. You're seeing fairly macroscopic, but extremely helpful nonetheless. We use it regularly. And then stimulation, actually intraoperatively putting electricity on the brain, in the brain, to see where we are, to stimulate things like language or motor function so we can map things out. We've got fluorescence guidance. And I think I showed you guys this on my talk last week. Fluorescence guidance has to do with giving a molecule, the patients drink a molecule that is then metabolized in the tumor tissue, and the tumor tissue turns it into another molecule that glows in the dark, basically, when you shine a blue light on it. And it looks just like this. And this has been proven to help us with surgery. So again, that goal is getting all the tumor out. If it's paint by numbers, it's a lot easier. We're able to kind of carve it out, look for the color differences. We can see a difference between normal brain and abnormal brain. Whereas before, it was just kind of this like gentle, fading out of a blush, maybe sometimes. This is a lot more discriminatory. And that's the same image, right? You can see exactly where the boundaries of this thing are now. And so we get into this problem, though, which is how much surgery is too much surgery. So we know that getting it all out is good, but we also know that if we hurt someone, it's bad. And it reduces or reverses that effect of taking out the whole tumor. So the complications are going to diminish quality of life and impact survival. We know that if we give you a permanent language problem or motor problem, it's going to negatively impact your survival. All right. So that benefit, where neurosurgeons are now the good guy, where we take out your tumor and we're all, giving each other high fives. If you cause a problem like this, you've really, really reversed that. You've got no benefit out of it. The most common complications are stroke and hemorrhage. Stroke due to injury to a passing vessel, whether it be an artery or a vein. Hemorrhage is that basically these tumors are very hemorrhagic in general. They're vascular. And so if you don't remove the whole tumor and you have some residual blood vessels that are abnormal, because they're abnormal blood vessels, because they're tumor vessels, they can bleed, and that can be a problem. But those are also the only ones we monitor. So there has to do with hospital administration and metrics, things that we actually calculate. But what about all the other problems that you can have? These deficits, I call them in non-canonical networks. So, and we're going to get to networks, I promise. But language and motor are two very kind of big concepts that are kind of easy to understand. It turns out they're a lot more subtle than that. But what about things like concentration? It turns out about 80% of glioma primary brain tumor patients are depressed or anxious, whether that's due to the situation or due to some intrinsic pathophysiology. Or what about being able to pay attention to things, concentration, some of the more subtleties of language, and what happens if you injure those, and do we even measure that? And it turns out we probably don't. And so we figured out how to do this now, a few years back, something called tractography and functional MRI. Tractography is looking at water flow down axons, and we're able to see the tracks in the brain. And axons are telephone wires. They go from the cortically based neurons, and they transmit information. And they transmit information next to each other, something called a U fiber, locally from gyrus to gyrus in the brain. They transmit to the other side of the brain in these big descending white matter tracts that go there. And then they also transmit information to your body in things like the cortical spinal tract, big white matter bundles that travel all the way down your spinal cord and go, past your neck to the rest of your body. So that's amazing. We can map that now. We can see those things. And then functional MRI has you lay in an MRI machine and perform a task. And when you're doing that task, it's looking at oxygen flow into an area, something called a bold signal. And that's because that area of the brain that's active is requesting blood flow and oxygen so it can work. It's basically, you got to feed it. And so we watch what it's being fed. And based on that, you can find out what the task is or identify the area associated with the task. So we can have naming. And let's say on the bottom right here, these areas will light up. And so putting these things together, we can start to say, all right, well, here's a really important area when we do this specific task, and here are the tracks that go out of it. But it's still not perfect because these tracks, if you don't know your tract anatomy, you just get lost. All of the white matter in the brain, meaning everything under the cortex, all of this stuff in here is a tract. And we know that it's all important, but some things are more important than others, and there's redundancies, and we don't know necessarily how to map that out preoperatively. So when we're designing a surgery where we don't want to hurt someone, we have to kind of take that into consideration. And so that's where connectomics come in. And this is kind of just iterative progress on something that's been being developed for a long time. And what they did was they made one company, at least for now, there will be others, but they made an off-the-shelf ability to look at your MRI with special sequences and map out your cortical areas of function and the connections that go to them, and the areas that all fire synchronously in networks. Networks, remember, are temporally connected. So when one area maybe in your language system is firing, the other area in your language system is also firing in a correlated, temporally matched way. And if this is going over your head a little bit, I'm sorry, but we'll try to explain it to the best of our ability. It turns out there are a lot of networks. There's about 8 canonical networks that we know about. And then these can even be parsed down to sub-networks within. It gets really complicated. But things like language networks, auditory networks, meaning when you hear things, these are the areas that are involved in that. Central executive is kind of the network that allows you to take what you want to do in your brain and make it happen. So this is what makes us kind of human. So our higher level of human functioning, our kind of ambitions, our desires, things like that, making them actually happen is central executive. Default mode is the opposite. That's our internal mind. That's our daydreaming. That's most of you who are now bored of me talking about networks, thinking about what you're going to do for the rest of the day. Dorsal attention has to do with exactly that: attention, paying attention to things, focusing on things, being able to shut out stimuli that are trying to steal from your attention. Language is language. We talked about that. Limbic, paralimbic has to do with kind of emotional responses. And then these get a little more crazy. Salience is a really important network. This is the one that tells you which network you're going to turn on. So it really oversees default mode and central executive. And it's a really important one. Ventral attention has to do more with things that startle you. So let's say I'm giving this talk and my nurse blasts in the door here. I'm going to turn and look at her, and that's my ventral attention. That's more primitive kind of protection one. And then visual is vision, which is an incredibly complex and well-studied network. And so why do we care about this, right? And this is a summary of kind of everything we've talked about for the past 20 minutes. Safe maximal resection is good, okay? Post-operative deficits are bad. And so those of you who know brain turns, remember my brain good, tumor bad analogy. This is that, okay? We need to preserve the brain. We need to get rid of the tumor. But preserving the brain is more than just preserving that mush of tofu. It's preserving all the function in there. And so the guy who developed this program refers to this as the oncofunctional balance, which I think is a really great term, because you want to get that oncologic result where you're going to affect this person's diagnosis, prognosis, but you're also going to maintain their function. And maybe we can look at this and improve people's quality of life while they're dealing with something that remains fatal, while the oncologists, molecular oncologists, John Bookvar's trial team and everyone continue to find ways to treat this. So this is just a case. This is a 31-year-old. She works on Broadway. She's having headaches and vertigo and what sounds like seizures, these kind of episodes of being disoriented. And I apologize, Christy and Samantha, I can't see the chat. So if people have questions or anything, feel free to just shout out. Um, but anyway, so these things are happening multiple times a day. And she gets an MRI finally, and she's got this lesion in the left frontal lobe. And it's in an area known as the premotor area or the supplemental motor area here in the superior frontal gyrus. And it's non-enhancing. I'll give you a hint. And it looks to me like a low-grade glioma. And so what we know about the supplemental motor area is that it's the area that makes the decision to move, basically. So if you injure it, people are left with the inability to move half their body. So in this case, on the left, you would lose the ability to move the right side of your body. And it does recover, but it takes usually anywhere between 2 weeks and like 6 months. And on the left side, you can lose the ability to speak as well. And so for this young Broadway person, that's devastating. And so we were able to get a connectomics image on her, and you can see all the areas that are involved. And it's a little bit small on your screen, but I'll try to point it out. So in the top left here, this is the central exec, that outward focus area. You can see it's right on the anterior boundary of this. It's preserved, but it's there. The frontal aslant tract, as turns out, is really critical to that SMA problem. We call it an SMA syndrome. And so preservation of this means you get better faster, or you don't get it at all. So preservation of this is actually really, really important. You can see it's part of the language system. It lights up when we look at the rest of the language system. And we can see the rest of the language system is actually fairly far away. It's not going to be an issue. Although these parcels get a little close, we'll be far enough away from that. And then our sensory motor system, which the aslant tract is involved in, right? The SMA has to do with motor, supplemental motor area. And so it's involved in that aslant tract as well. So we know how important that is. But one thing I want to point out is how close we are to the motor strip on the back end. So if we go too far medial, we injure her. And if we go too far posterior, we injure her. And this is irreversible. The medial stuff here in the middle, that's reversible, but it's a real deficit. It's 2 weeks to 6 months of recovery for this. And so we use this in the case. This is just information on the SMA syndrome. This is how many people present with problems in certain regions. And you can see actually it's a big number. Where is it? Motor deficits in about 97% of them. That's the primary issue. But what I thought was interesting is speech problems in 50%. All right. So that's a big deal when you work in this area. And we've written about this. So before we go into the surgery, we always want to think about what we're going to use in the surgery to make it better. And so neuropsych testing is really important because we're studying things that aren't measurable now. All right. This is not the ability to squeeze your hand in the operating room. This is an area that makes the decision to squeeze your hand. So you can't just electrically stimulate this, or we don't know if you can anyway, and see that. And let's say we were in one of those attention areas. How do we know that we have a problem or don't have a problem? So neuropsych testing is paramount. I have a very low threshold to do awake surgery. We talked about this the other day, where some of the nuances of language in particular, you can't do it if you're not awake. It's just, there's no way yet. Maybe down the road, maybe with these, maybe once this AI note taker that you guys are using figures out what language is, it can help us. But for now, it's awake surgery or bust for me. What kind of stimulators you're going to need and use. And these are things, once you finish your residency, we'll talk more about cortical and, subcortical stimulation and Ogemans, or Dr. Silverstein will talk a little bit about it. Do we want fluorescence? This is a low-grade glioma. We don't really need it. These are our subcortical stimulators. These are homemade. We basically, there's a company that sells these, but to reduce costs, we figured we can just make them ourselves. We don't use this red thing anymore. We just use a Tegaderm, but this is a game changer. Actually, Justin Silverstein, the guy you're going to hear from later this week, sent me an email from a team in Texas now that has adopted our technique. And I got a call from someone who trained me, who I think is a fantastic surgeon. And he called me once at like 6 or 7 p.m. And he said, I'm simultaneously so mad and so proud of you. He's like, I can't believe I didn't think about this before. This is incredible. And so this is just one of the things that we've done that I think it's a game changer, so easy to do. And it really changes the way surgery is done, for me anyway. But more than that later. So anyway, we do our surgery and we map out these areas with our GPS system. We use our ultrasound to see the tumor, and we use our stimulation to stimulate, and we keep her awake and she talks to us. And the tumor's out, and we preserve that central executive network, and we preserve that frontal aslant tract, and we preserve that sensory motor system. And we take out as much of that tumor as we can. It's a gross total, which is great, um, with preservation in these areas. And the question becomes, how do you was it necessary? The tumor didn't look like it was invading that anyway, so maybe you could have preserved it anyway. And the analogy I always kind of think about is if you're running in the middle of the night and you have no idea, but there's a cliff in front of you, you're going to go full speed and blast right off that cliff. You just don't know. But if you have an idea that something's coming, maybe you slow down, or maybe you're more careful in that one area. And that's kind of what this has allowed us to do in these areas that we don't know how to monitor yet. And we will figure that out. But right now, while we don't know, we just be a little more careful. Some might say, well, what are these colored dots? Maybe they're not real. And we've looked at this. This is the green line here is my electrode, that suction on the back of the brain, and it's stimulating positive for the motor strip in these areas of the motor strip. So you can see these blue dots in the back. This is intraoperatively what it looks like. And that's me stimulating and confirming that that is where it says it is. And we've done this with language, different case, but in looking at these critical language areas in the language network, all these, picture all these bubbles around the brain, intraoperatively, when we stimulated, we would get a speech arrest, or we would get what's called a paraphasic error. And we published this. This is correlated, and it's a valuable study without a doubt. And so what I find super interesting is when there's differences. So these two tumors are in basically the exact same place. They're both in the SMA. This is our low-grade glioma patient. And here's something called a cavernoma. A cavernoma is a congenital issue, meaning you're born with this. And it's different than a tumor in how it develops. And so the cavernoma, presumably in this situation, I would have thought that that frontal Aslan tract would have been pushed inferiorly and squeezed down here. Based on where it is supposed to be located in the superior frontal gyrus. Well, it turns out when we did our connectomas analysis, we can see in the tumor, it's on the inside where it should be here at the superior middle frontal gyrus, sorry. And then here on the cavernous malformation, it's on the other side because this is a developmental problem, not something that developed over time. And so now, instead of being like, oh, I'm going to be really, really careful at this deep part where this is going to be, again, that cliff in the night kind of analogy, I'm going to be careful on the outside of this, not on the inside of this. And that gives me some insight into how I'm going to do and approach my case. So the core principles of how we're using this. So location in the brain is everything. It's real estate, right? What are the goals of my patient? If my patient thinks that they're okay losing the ability to concentrate and do math really well, maybe I'll be more aggressive in certain areas. If they're an accountant, then absolutely not. If this is the motor strip and they're, especially like a violin player, we have to be really, really careful. We're going to be very, very careful. We're going to use this to help us with that. What are the goals? If I think that I can't safely remove a tumor, is that as important then? I'm leaving stuff behind regardless. What's the grade of their tumor? Low grade? Is this a high grade? The reason I bring that up is people with experience will tell you that if someone can do something before surgery and they have a high grade tumor, then it probably won't be affected post-operatively unless you go really beyond where it is. And that's okay. That's true. I would say that if you have a high-grade glioma in one of your language areas, but you're able to talk before we do the surgery, you're probably going to talk afterwards. It means those areas are protected. But again, let's see that. Let's know exactly where it is so we can slow down in that region. Oops, I think I clicked the wrong button. Hold on. Yeah. And then what are we going to treat with post-operatively? What do we need intraoperatively? And then the question that I've been really asking myself moving forward is, what are we going to do post-operatively with this? And so can we use this as a guide to target therapeutics and make people better? So TMS is something, it's kind of a hot button object right now. It's transcranial magnetic stimulation. It's FDA approved for anxiety and depression, treatment refractory anxiety depression. It's actually FDA approved for migraine treatment also. And I have one patient who's had a lot of success with it. I am very careful to be a promoter of this. I am not a promoter of this. I don't know it at all. I'm trying to, but there are a lot of people out there who say it's a game changer and helpful. A lot of times in these situations, any little bit helps. And so people are willing to try it. The idea though, is that in areas of hypofunctioning or hyperfunctioning, cortical connectivity, you can turn it off or turn it on. And you can potentially bypass areas that aren't working as well or that are injured through a surgery and recover some function. Again, the jury's out in my mind on this. I'm still doing work on it. but in conjunction with physical therapy, can we stimulate these areas of the brain? Can we be more targeted with it using that MRI that we can get to figure it out? And then pharmaceutically, can we augment what we're doing with physical therapy or TMS using drugs? And can we be smart about those drugs? And so this is a case for that. This is a big right frontal glioblastoma. Talked to the family extensively beforehand. I mentioned that it's involving the default mode network and parts of the central executive network, and you may have issues postoperatively with something called abulia. Abulia is, I think, do I have a slide on it? Give me a sec. Maybe, yeah. It's marked apathy. So it's basically a lack of spontaneous anything. It's blunted affect. It affects your decision making, your goal directed behavior, and you can see here's our surgery. And it's a nice clean surgery. We affected those two networks, and she woke up and she couldn't do anything. She was just bedridden. Her eyes were open. She was moving, but if you asked her to do anything, she wouldn't do it, and she wouldn't produce any spontaneous speech. And this is a profound abulia. We ruled out all the negatives that could be happening, and we diagnosed her with this. And so, how do we treat this? So we looked at, her pre and her post-op films, and we saw what networks were affected, and it was really the default mode in the central executive network. And these networks are anti-correlated. If you're in your default mode, like most of you now bored of me are, your central executive is off. But the minute you want to leave this or post something in the chat, you're switching. You're going into the central executive, and the default modes are off. And the salience network is helping you kind of do that. And it turns out, this is kind of the baselines of these. So default mode, active at rest, not focused externally, your self-referential thoughts, your theory of mind when you're making plans for the future, versus the central exec, which is really, focusing that attention, keeping things in your working memory, decision-making, problem solving, outward expressing stuff. So these interact. We just talked about this. So any sort of imbalance here is going to cause abulia, and that's been studied. If you're not turning off your default mode with your central exec, you're going to get abulia, or if you're having difficulty switching back and forth. And again, it's due to atypical activity, basically. So how do we fix that? So dopamine is a huge component of this. Dopamine is a neurotransmitter, for those who don't know. And what it does is it turns on the central exec. It stimulates you to do something, helping your attention, your decision-making, your memory. It turns off that default mode, your internal mind, and it improves connectivity between the two, so they're cycling back and forth faster and better. Dopamine is made in the midbrain, and it's transmitted all the way out to your cortex via these kind of pathways. And if you look at this blue line here, you'll remember that I cut this out. This is gone on this woman on the right side, and in addition to some of those cortical parcellations that handle the function. And so we have drugs that do this. Sitamet is a drug we give Parkinson's patients. Now remember, Parkinson's patients don't have dopamine. They stop being able to generate it. And it's converted immediately into dopamine in the brain. And then we've got these stimulants. They do a little bit of a different job. They're reuptake inhibitors, which they don't really make more. They just leave behind more and available more. And then modafinil is another stimulant that deals with more glutamate. It's a different, or acetylcholine, different what altogether. And so, we basically chose Cinemat, and we gave this patient Cinemat. Within about 4 hours, she was talking. Not perfect, because these are complex situations, but opening her eyes, talking, following commands, which argues to me that we can give these drugs to help our other efforts, things like time and healing and waking up other parts of the brain or physical therapy. And it brings up this idea of connectopsychopharmacology, which is basically, and this is a crazy chart made by a really impressive medical student. This is every parcellation in the QuickTome Atlas. So in that Connectomics Atlas, and it's every neurotransmitter and whether or not they're up or down based on certain drugs. And so it's a pretty incredible. And so this is how we can use this information to maybe target pharmaceutical adjuncts to therapies. And this is kind of something that we have to think about a lot. This is hard. This is something where your AI assistant might be able to give us answers. And so we're studying this here. They were part of a consortium called the Glioma Connectome Project. The auxiliary research trials team, who I think are sitting outside here, may hear some talk about this upstairs. We're getting ready to go. With this, we're giving patients that neuropsych testing. We're using a rudimentary thing called the NIH Toolbox. We're getting these scans pre and post-op and down the road, and we're seeing how people change and how their cognition changes with their brain structure and architecture, to give us insight into how to do these surgeries safer or how to monitor some of the stuff that we don't know how to monitor. And then it turns out that surgery is not the only thing that affects this. So giving people chemotherapy, this has been long looked at, gives people this kind of brain fog. And it's due to changes in these functional networks. And so we're going to look at that also, studying chemo brain here. We were just given a grant for this as well. So we have these two grant funded studies. And this is another one looking at radiation. And so we haven't even addressed radiation yet. And this is a glioma. Was resected, it came back, was resected again. You can see the optic radiations are preserved each time. Here they are here, here they are here. And so this guy got something called gamma tau radiation seeds in the cavity, and this around it is not progression, but it's radiation necrosis. And what you notice is the optic radiations have been trashed by that. And that is the effect of radiation on these networks. And so it doesn't have to be intraoperative radiation. External radiation, when we give something like gamma knife radiosurgery, also will affect these things. And so we're going to start studying how this happens through another project that was just awarded funding, actually looking at brain metastases and connectomics, because there we use a lot of stereotactic radiosurgery. So we've got these three really fantastic funded studies that are going to help us figure out more about this, which will be great. Brain tumors is one component of this. This has to do with the brain, right? And functional imaging has been looked at for a long time in a lot of different networks. And I don't know if any of the students who helped me with this are on here, but we've written a pretty comprehensive paper looking at the applications of functional MRI, which also means it's the applications of connectomics. So mental health, movement disorders. One of our residents is an MD PhD and has studied Parkinson's and how this is a network disorder. And maybe we can treat this with network, adjuvants. Epilepsy, things like Alzheimer's, TBI, stroke, vascular abnormality, everything. Every component of brain health is going to deal with network connectivity. And so these are all areas that are ripe for study. And so this is something I'm profoundly interested in. And I think it's one of these things that are going to hopefully change how we do these surgeries, or at least how we think about these surgeries. This is my final word of advice. It works if you work it, so network it, you're worth it. I think that's the end of my talk. I want you guys to also just be aware, we're neurosurgeons. And I talk about this all the time, but neurosurgery uses a knife and some string to help people. That's crazy. Okay. The brain is full of network connections, all these complex neurochemical synapses, and we're using a piece of steel and some string, and we're like, we're going to fix you. Don't worry about it. No problem. The true people who are going to help brain cancer patients are molecular biologists. There are neuro-oncologists who are doing the cutting edge research. So the people who are running the clinical trials, putting that into actual practice. The surgeons here are never going to be the person who cures your cancer with a surgery. And so if we're going to do this to you, let's do it right. Let's keep the framework that makes you still a human being there, so that maybe we can actually figure out ways to recover you, and let the molecular biologists cure your cancer. That's great. We're going to do that 100%. These AI assistants probably figured it out while I was talking and they summarized it already. But when I do my surgery, let's keep the house, the framework of the house built, so that we can reconstitute, a good quality of life for you. And so that's kind of my obsession these days. Anyway, I went 40 minutes. It's time for questions. I'm sure there are some questions. And we're going to wait for our next group of people.
Yeah, there's a couple already in the Q&A section. So they had asked if there have been people that have tried or been able to repair these networks. I'm guessing if you were to go into the network while resecting is what they're asking.
Yeah, so I don't believe you can repair a cut telephone wire, right? This is different. Maybe down the road we can figure that out. But for right now, if you cut the networks, if you cut the subcortical connectivity of these things, that's a big issue. But let's say that there are 2 points in space. Okay, this is my stuff. And let's say there's a node in between those 2 points in space. All right. and they're connected in a straight line here. And let's say there's like a fourth, this is the worst analogy ever. There's a fourth one over here, and maybe there's some different connectivity. And let's say we take this one out, we cut it, and there's a longer route of travel, but it's still connected. Can you make that longer route of travel more efficient and still convey the same information? And that's what we don't know. Or can we use medications or TMS or physical therapy to make that alternate route, almost as good as the previous route, right? The obvious thing is don't cut the telephone wire. So if you know it's there, you can avoid it. But that's going to be at a microscopic level. I don't know if we're ever going to be able to do that. And so then the option is leave it with a little bit of tumor on it and cure your tumor. That's a good way to do it, right? Or use a different telephone wire.
Yeah. Another person asked, what cases do you prefer to use the fluorescence in?
5-ALA or glial is FDA approved for high-grade glioma, so grade 3s and grade 4s. I will sometimes use it if I think something is a grade 2. Remember, we don't know the grade until you're in the operating room. But if I think something might be a higher grade, I'll give it, because if it fluoresces even a little bit in a low grade, you want to biopsy that. You never want to undertreat someone. And these tumors are not just one uniform mass. They're all different throughout it. So you want to biopsy the highest malignancy, the part of it that is the most aggressive, because that's how you're going to tailor your treatment. So I'll use it occasionally for that. But high-grade gliomas, I use fluorescence now for meningiomas too, especially on the skull base, because it allows me to see if I'm leaving little satellites that may prompt recurrence. So that's how I'm using that now. We just published a paper on the efficacy, I think, in metastatic disease. And I've published it previously. It's about 50%, 50-50 in metastatic disease. We need more work on that. 5-ALA may not be the answer. Something like fluorescein might be better there. But there are different agents and there's more coming out.
Awesome. Somebody asked, would tools like gamma knife surgery help in preventing damage to critical tracts and structures?
Oh man, did they ask that before my slide about the effects of radiation?
I don't think so.
Radiation affects things, right? It may prevent it depending on how robust it is, but radiation causes white matter changes. And so yes, radiation is probably more gentle than a knife or a cautery, but it's going to affect it the same way. And the truth is just no one knows right now. So this is stuff that we're going to be looking at.
Somebody else says, when the connectomic analysis indicates that a tumor is far from any important structures, what drives the decision on how much of the surrounding normal-looking brain should be removed? And then I'll ask the second question that goes in that. But
yeah, that's a great question. So I told you more is more at the very, very beginning of this talk. Extended resection matters. Well, it turns out there's a camp of people out there who say that supratotal resection matters. Now, this is a super interesting story. When gliomas first came in the field, we had no idea what to do with them. We were just taking out what we thought we were taking out and whatever. People weren't doing well. Then we learned with MRI with contrast, if you take out the contrast enhancing portion, people do better. Then they started saying, well, if you take out the contrast enhancing portion and a little bit more, they do even better. But like 100 years ago, people would take out half the brain and these tumors would still come back. It is still an incurable disease. And so how much is too much, right? That was one of the questions in the talk. How do you draw that boundary? And so if possible, and this is where I think connectomics can help you, you can try to get a supramaximal resection. 90% of these tumors recur within 2 centimeters of the original. And they often have swelling around them, and that swelling around them, that flare positive edematous area has tumor cells in it. And so that is that oncofunctional balance. And that is exactly, I think, how you can use this to maximize your resection. Now, it's hard. I mean, the more you look at the importance of the brain, it turns out that the brain's pretty important. So there's no areas that do nothing, or else it probably just wouldn't be there. So you have to make decisions, and they have to be educated decisions. That's why we need to know about these networks to know, can I take your right-sided central executive network because the left side will pick up the pieces and fix it, right? If there's redundancies, are you going to be okay regardless? Or maybe it's already dysfunctioning. I didn't show this, but there's a new way now using resting state fMRI in the same software to look at maybe one area is functioning and the other area is not functioning. And does that mean we can take it, with reckless abandon? So It's a great question though.
Yeah, the second part of their question was asking if connectomics can be used outside of neuro-onc and to perform targeted surgery on a network that is overreactive or not functioning properly.
So, yeah, again, great question. It gets into two questions. So, can you modulate a network without surgery? So the TMS question. So yes, you can turn off and turn on networks with TMS that are hypo or hyper functioning. And then number two is what surgeries can we do that with? And so there's a few different ones, right? We do DBS for Parkinson's, so we can put electrodes in places. We do RNS for epilepsy. And we do high frequency ultrasound or low frequency ultrasound now in places. So can we do that? And the answer is question mark. I think we're waiting. So let's figure it out.
Somebody also asked about if stem cells could possibly be used for network reparation.
Yeah, they're not there yet, right? So maybe one day. I think people are actively studying how to reconstitute network connections and white matter tracks, right? This would be huge if you could fix people with MS by reconstituting axons. I mean, what I would tell you is go figure it out, and then your grandkids will be set for the rest of their life. So.
There's another question about they say since chimeric antigen receptor T cell therapy is working relatively well right now, would it be a preferred method to treat glioblastomas?
Yeah, who says it's working relatively well right now? I don't buy that. I think that the study that went out in the New England Journal and wherever it was had problems. And actually, if you read it, didn't really show a meaningful response at all. And so that is far away from the benefits they want. There's enough benefit for the New England Journal to think, wow, this may be onto something. But right now it doesn't work. And so that's really important. There's not going to be a single fix for this disease. And I'm happy to talk about this disease at another day, maybe. But if anyone's ever read The Emperor of All Maladies, it's a book, it's a biography of cancer written by a Columbia oncologist. It's an amazing read. And I'm not a super avid reader anyway, but it's really an amazing book. The way we cured pediatric cancers was like, and pardon my metaphor, shock and awe. We gave 5 chemotherapies to a kid and we obliterated their cellular composition basically because kids bounce back, and we were able to cure childhood cancers. And that was a big win. We treat glioblastoma with 1 drug and some radiation, and adding 1 other drug is probably not going to win that. So we need to, and unfortunately you can't study 5 drugs at once. It's just, there's too many confounders. No one knows what to do. And so it's going to be iterative progress. It's going to take a long time. Hopefully things like, the AI revolution are going to help us do this faster. But, one drug is not going to beat a tumor that's comprised of extremely different cells, and that varies in different locations of the same tumor. It's just too complicated. So, yeah, I don't, it's a great option. It's showing enough or a little bit of promise, which is great. But again, I'll tell you the same thing I told stem cell people: go dive into it, do research, figure it out, and help us save people.
Yeah, somebody also asked if you could say what the name of the book is again.
Yeah, here, I'll put it in the chat. I think I can put it in the chat. Everyone. Anyway, guys, Emperor of All Maladies. Yeah.
Awesome.
All right, what else? I see that the PAs are joining. What we'll do is maybe take 5 minutes. So at 9:55, we'll take 5 minutes so everyone can use the bathroom.
All right.
And then be really rested for our PA, buffet, our buffet of PA advice.
Yes. Somebody says, how exactly do advancements in intraoperative imaging technologies such as fluorescent guided surgery and neuronavigation contribute to improving surgical outcomes and minimizing post-operative defects in patients with gliomas?
So the way that it helps is, where is that question? I want to read it.
Oh, sorry.
There's a lot there. It's in the answered.
Yeah.
Oh, here we go. Okay. So the issue with these tumors is because they're comprised of components of normal brain in addition to tumor. They're not always so easy to tell the difference. And when we look at our old studies about extent of resection based on MRI analyses, we weren't very good at this. We were getting, even the guys who said they were really good, gross total resection rate was like 40%, like globally, which is terrible. So adding these fluorescence guidance techniques really has amazing specificity as to what is tumor. Remember, specificity is, it is what you say it is, basically, or it's not what you say it's not, kind of thing. And so being able to identify that has changed the game. And the studies that came out for this, 2006, I think there was another one recently called the RESECT trial. These gross total resection rates are much higher, 60 to 80% using fluorescence guidance. And so we can get tumors out better. All right, that's how that helps you. And it's been proven. It has also shown us through the data, the outcomes data from those studies, that the people who get those tumors out live longer. So this is a win. This is I consider it standard of care. Not everyone does. In Canada, it's not. Sorry, Canada. But I consider it standard of care. Minimizing postoperative deficits is the part that it can't tell you anything about, because the fluorescence lights up tumor. If the tumor is on or in your motor or language system, it doesn't not light up that area. That's why we need other tools to identify those areas. So what I would say the benefit is, though, is that it tells you, it's the same thing as my cliff in the night analogy, right? If you know where something is, you can better prepare to handle it the right way. And the map is the territory, right? Isn't that the quote? Something like that. You know what you're dealing with when you know what you're dealing with.
Yeah. Somebody saw your new post this morning about the new trial and was wondering if you could talk more about it.
Yeah, so we're a site for the Plus Therapeutics leptomeningeal trial, which is studying intrathecal rhenium, which is a nuclide, basically a radioactive nucleotide that we put into the CSF space, and to treat leptomeningeal carcinomatosis. What that is when your cancer gets so bad it attacks the lining of your brain, and classically extremely difficult to treat. Typically a very unfavorable prognosis depending on your primary pathology. So if it's a glioma, breast cancer, lung cancer, whatever that is, the length of the overall survival following a diagnosis is like 2 weeks to like 3 months. It's really bad. And recently we started doing something called craniospinal radiation for that, where we radiate your whole brain and your whole spinal column. But that's external radiation, so it's going through you. And with the external beam, remember, I think I said it the other day, radiation has to pass through all your tissues. So you're going to get esophagitis or maybe a pneumonitis, meaning inflammation of the lungs or the esophagus or stomach problems. We have advanced that now where we use proton, which has a rapid fall off. So it's a little bit better and the evidence is good for that. Rhenium is actually putting it in the CSF itself. So it's bathing directly onto what needs to be affected. And so the prelim studies are really good. It's well tolerated. We don't know if it works yet. So we're part of a phase 1/2 trial to test it. And so I think it's a great option. It puts the treatment in the combined hands of the radiation doctors and the neurosurgeons. And this is our realm. And it's super awesome to be a part of it. And actually, we have to thank our trials team who are listening. These trials, getting a clinical trial started is an amount of work that I hate to think about. I just can't. It's the type of thing that if I had to do it myself would probably be impossible, but would at least take me all night every night for weeks and weeks and weeks. And our trials team is so efficient at it and so good at it. And it's why, the Brain Tumor Center here has been able to launch so many clinical trials. It's an art to them. They do it effortlessly. It's pretty incredible. And for the group of students that are watching them this week, you guys are fortunate, because I think that and again, I trained at Columbia. I was involved in clinical trials at Columbia. There was a whole basement with a room full of people who did this. And they were nowhere near as successful, efficient, or productive as our team. So it's just it's a whole different ballgame here.
Yeah. Well, I guess since it's almost 8:55, if you want to finish us off with a list of book recommendations that you may have. I don't know if you want to put it in the chat.
Oh man, I've been reading really boring stuff. I'll put it in the chat.
Okay.
That's
good. While you do that, I'm gonna just reminders, brain turns. I've been seeing a lot of like raising hands. We can't technically really do that right now
Yeah,
because webinar format. But if you have questions, go ahead and use
just
that
type it.
option. Yeah, and we will get to it. But yeah, so it's 8:55, so we're gonna take a nice little break before Arthur and all the other PAs join us to give us a wonderful talk. So everybody gets a 5-minute break, bathroom break.
I'll come in and do the introduction for you guys, Arthur. And Christy and Samantha, great job as always. Remember, guys, today we are going to end after the PA talk. So we're going to end at 11 today. Go recruit some people on the street or in the bathroom and come back. And thank you all for listening. Hope that was good.